Welcome to the importance of early universal screening to identify congenital cytomegalovirus. Thank you for joining us. I'm Denai Wells, Product Manager for Eurofins Viracor, and I will be your moderator today. If you have any questions during today's presentation, please submit them in the chat. Following the presentation, we will have a live Q&A. In this webinar, you will learn about the prevalence of cCMV and how it is acquired, the importance of early identification of cCMV in neonates, screening for cCMV and why it matters, how to identify cCMV with non-invasive testing, the advocacy work surrounding universal screening in the United States. Let's meet our first presenter, Dr. Patricia Purcell. Dr. Purcell is an assistant professor and clinical researcher in pediatric otolaryngology at C.S. Motts Children's Hospital. She earned her doctorate of medicine at the University of Southwestern Medical Center in Dallas, Texas, and completed residency in otolaryngology, head and neck surgery at the University of Washington in Seattle. She completed an additional 2-year research fellowship during residency, during which she earned a master's in public health and health services through the University of Washington School of Public Health. After residency, she moved to Toronto, Ontario, Canada to complete a 2-year fellowship in pediatric otolaryngology at the Hospital for Sick Children. She is passionate about patient care and public health policy relating to children with hearing loss. Dr. Purcell's research interests focus on improving our assessment and treatment of children with hearing loss, including children with hearing loss associated with congenital cytomegalovirus. Welcome, Dr. Purcell.
Thank you for the introduction. I'll be presenting on congenital CMV, transmission and prevention. Just some brief disclosures. I'm an assistant professor of pediatric otolaryngology at the University of Michigan. I'm a co-chair of the Associate Board of the National CMV Foundation, and I'm a primary investigator for the University of Michigan Sound Support Program, which provides outreach services to children who are deaf and hard of hearing throughout the state of Michigan. So let's start talking about cytomegalovirus, or CMV. CMV is a member of the herpes family that's endemic around the world, but seroprevalence varies from nation to nation. For an otherwise healthy individual, contracting CMV will likely produce upper respiratory symptoms, something similar to a common virus or a cold. But it causes more serious disease in immunocompromised individuals and fetuses. Congenital CMV occurs when a fetus is infected in utero. And in fact, it's the most prevalent congenital infection in the developed world, affecting 1 out of every 200 births, according to the CDC. Importantly, 1 out of 5 children with congenital CMV will develop long-term health problems. And many are not aware that congenital CMV is the most common cause of non-genetic sensorineural hearing loss. This knowledge gap has been noted. So if we look at common conditions that impact pregnancy, we can see in this graph that CMV is more common than fetal alcohol syndrome, Down syndrome, spina bifida, HIV/AIDS. However, women's self-reported awareness of these diseases shows that there's a gap. Only 14% reported awareness of CMV, contrasting with the other conditions for which over 75% of women self-reported that they had some knowledge. So how do we close this gap? First, by understanding how CMV is transmitted. CMV is shed through bodily fluids, such as urine, saliva, blood, mucus, and pregnant women typically catch CMV from young children's saliva and urine. A lot of this can happen when they're performing caregiving activities, such as changing diapers or feeding an infant. Toddlers often shed CMV. Young children can shed CMV in bodily fluids for variable lengths of time, from months to even years. Because CMV is so common, routine screening and testing of children is not recommended, because most children who are after birth will not have serious impact from CMV. The distinction happens whether a child is infected before birth versus during childhood. Congenital CMV infection is the result of intrauterine transmission of CMV from the mother to the fetus. And the highest risk of congenital CMV occurs when a mother experiences her primary or first infection during pregnancy. However, congenital CMV can also occur in a mother who has previously had CMV if there is recurrent virus or reinfection. To review some important definitions to help clarify these points, seropositivity is when a mother has anti-CMV antibody present in her blood work. This indicates that she's been previously exposed to the virus and has some immunity to it. Seronegativity is when there is no antibody present in the blood. This indicates that an individual has never been infected, or if they were infected, they've lost the immunity. It has waned over time. Again, primary infection is when a seronegative mother is infected with CMV during pregnancy. Studies have found that seronegative mothers have a 4-fold higher risk to deliver a baby with congenital CMV after pregnancy. And because of this, oftentimes CMV antibody status is determined prior to pregnancy. Primary infection is also more likely to result in severe or long-term congenital CMV. Again, there are other forms of congenital transmission in mothers who have previously been infected. Reinfection is when a seropositive mother is infected with another form or variant of the virus. Reactivation and recurrence occurs when a seropositive mother who is carrying the virus experiences a reactivation of a dormant virus. Congenital CMV has been found to occur in these situations, but the thought is that it is probably less severe. Overall, the incidence of congenital CMV, in developed nations, it impacts between 0.5 and 1% of pregnancies. Of these pregnancies, the newborns will be symptomatic in 10 to 15% of cases. This means that they will have clinically obvious signs of infection, such as intrauterine growth restriction, blood work abnormalities, or neurologic differences. 85 to 90% of the children will be asymptomatic, and that they may not have clinically obvious signs at birth. However, in this asymptomatic group, we know that a fair proportion, between 10 to 15%, can actually develop sequelae such as permanent sensorineural hearing loss. So identification is important. This is a graph showing the spectrum of symptoms that can be experienced by babies with congenital CMV. As you can see, it ranges from the severe, even involving stillbirth or miscarriage, to the very mild, in which babies essentially have no impairment. Most babies will fall somewhere in the middle, and that's why diagnosing CMV early in life is important, so that early intervention can be established as needed. Thank you for learning about CMV.
Thank you, Dr. Purcell. Next, I'd like to introduce Dr. Gail Demler-Harrison, a professor of pediatrics at Baylor College of Medicine and attending physician in pediatric infectious diseases at Texas Children's Hospital. She has almost 40 years experience in research and clinical care associated with viral infections affecting newborns, children, and adolescents. She is most interested and experienced in studying all aspects of cytomegalovirus, or CMV, including the biology, epidemiology, clinical manifestations, long-term outcomes, diagnosis, treatment, and prevention of congenital CMV. She also runs a busy CMV clinic at Texas Children's Hospital and cares for hundreds of children and their family affected by congenital CMV. She is a tireless advocate on behalf of children affected by cCMV.
Hi, and thank you for that introduction. Let's talk about screening newborns for congenital CMV. And what I'd like to talk about is 3 basic things. Can we screen newborns for congenital CMV? Do we have methods available? Should we screen newborns for congenital CMV? What are the pros and the cons of congenital newborn screening? And finally, do we screen newborns for congenital CMV? Are there current programs and advocacy efforts for congenital CMV newborn screening? So first, can we screen newborns for congenital CMV? And the answer is yes. And there are three important things to remember. First is timing, second is specimen, and third is method. So first, timing. There is a critical window of opportunity of the first 21 to 28 days of life to detect CMV in the newborn, to diagnose congenital CMV. After that, since CMV is so common, we can't tell if the baby was congenitally infected or postnatally infected. Second is specimen. Newborns with congenital CMV are born shedding large quantities of the virus in their saliva and their urine. And those are ideal specimens to detect CMV in newborns and very useful for newborn screening for congenital CMV. Now, many babies are also viremic with CMV at birth, and so we can also detect CMV in their blood or their plasma. And another unique way we can detect CMV is through analysis of the newborn screening dried blood spot, because the CMV DNA can also be detected there. And finally, tissue. Through biopsy or autopsy, we can also detect CMV. And finally, the method. There's two basic methods that are used now to detect CMV in newborns. One is viral culture or enhanced shell vial culture. Those are traditional methods. Some labs still use them, but most labs will use polymerase chain reaction, PCR, or other nucleic acid amplification assays. So remember, timing, specimen, and method. Now, what about newborn diagnosis of CMV? There's diagnostic testing, there's targeted newborn screening, and there's universal newborn screening. Now, diagnostic testing is the here and the now. Newborns with signs and symptoms of congenital CMV are tested by their physicians or their advanced providers. Many newborns, however, with congenital CMV are still missed. For example, babies who are symptomatic, especially those who are mildly symptomatic or atypical in their presentation, or may have a primary neurophenotype. And by that, I mean they don't have the classic signs of petechiae and hepatosplenomegaly. They may just have brain involvement. Studies have shown that many of these babies are missed or delayed in their diagnosis. And finally, asymptomatic babies, which is the vast silent majority of babies congenitally infected with CMV, will not be detected through diagnostic testing because they look totally normal. Then there's targeted newborn screening, and that's evolving. And that's where normal newborns with failed or referred newborn hearing screens are tested for CMV, because CMV is a cause of congenital hearing loss. Not the only cause, but an important cause. And then there's universal newborn screening. And I put waiting on my slide, but then I changed it to evolving, because the reality is universal newborn screening is almost here. And that means that all newborns will be screened or tested for congenital CMV. Now, should we screen newborns for congenital CMV? We can, but should we? Well, there are pros to screening newborns for congenital CMV. It has been shown to be cost effective. Both targeted screening and universal newborn screening are cost-effective strategies. And to learn about that, I put some references at the bottom of my slide so you can learn about that more in detail. Now, the early diagnosis of CMV-associated congenital hearing loss, or microcephaly at birth, or other neurodevelopmental disorders will minimize further invasive and costly genetic testing and other imaging testing. And so if you detect CMV in the newborn, you won't do those more involved tests. And we can make roadmaps and algorithms that can be provided for parents, pediatricians, audiologists, otolaryngologists, therapists, early intervention programs, and other healthcare professionals and educators also to guide the management of these babies. Also pro is that most newborns with congenital CMV are missed and they're not diagnosed. So screening for them will detect these babies. And then early diagnosis will allow for antiviral treatment when it's indicated, and to start within the recommended window of opportunity, which is the first month of life. Early diagnosis of congenital CMV also allows for regular audiologic follow-up to diagnose hearing loss early. Early diagnosis of hearing loss improves speech language outcomes and educational performance, and that's a fact. And finally, a definitive diagnosis provides parents peace of mind and reduces that stressful diagnostic odyssey. Now, of course, there's cons to screening newborns for congenital CMV. For example, most children born with congenital CMV and who will test positive through universal newborn screening will have no symptoms and no sequelae. So what's the point of detecting them if they will live a normal life? We also may produce an undue burden on our healthcare system. We must then plan for an enhanced capacity because that will be needed in many entities. For example, laboratories will need enhanced capacity for CMV diagnostics to confirm positive CMV screening results. More audiologists will be needed for the increased hearing evaluations that will be needed. And there will be more medical encounters, more therapy encounters that will be needed to evaluate and manage the identified congenitally infected newborns. Will we create a worried well of parents and families? And finally, will the off-label use of antiviral treatments such as valganciclovir, which is readily available now, will it be offered to patients and families without a proven benefit and with potential risks? So we've found out that, yes, we can screen newborns for congenital CMV. We've looked at the pros and cons of should we screen newborns for congenital CMV. And so now let's look at, do we screen newborns for congenital CMV? Is anybody doing that? Well, targeted newborn screening for congenital CMV with failed or referred newborn hearing screens is the here and now. It is being done now. There are many states that by state law, do perform targeted newborn testing. Utah was the first state, but Connecticut, Iowa, Illinois, New York, and Virginia also do. Many birthing hospitals, the one I work at included, and many other states will voluntarily perform targeted testing for newborns. And for a list of all the states and hospitals to see if your hospital performs it, you can go to the National CMV website and look at their list. Now, targeted newborn screening for congenital CMV will allow early detection and management of infants for congenital CMV-associated congenital hearing loss. But it's not going to identify infants who don't have hearing loss at birth and who are asymptomatic. And it won't identify infants with other manifestations of CMV who may develop later onset hearing loss or other sequelae. So what do we do there? Well, many CMV advocates are advocates for universal newborn screening for congenital CMV. Now, there is a key component to making this happen, and that is the Recommended Universal Screening Panel, or RUSP. It is a key component for any universal newborn screening program. Now, a RUSP application has been submitted in 2019 by the National CMV RUSP Multidisciplinary Nomination Team. It's now under review by the Advisory Committee on Inheritable Diseases of Newborns and Children. And to learn more about this effort and maybe support it, once again, you can go to the nationalcmv.org website and learn more about Universal Newborn Screening RUSP panel application. Now, it is the here and now in one state, Minnesota. It was the first state in the United States to enact universal newborn screening for congenital CMV. It was the Vivian Act, in honor of Vivian Henriksen, a baby who was born with congenital CMV, and she has suffered hearing loss and cerebral palsy. And this program will use the newborn dried blood spot CMV PCR testing method that has been published and has been shown to be very effective with up to 85% accuracy reported when compared to other methods such as detection of CMV in the saliva and the urine. Are other places looking at universal screening for CMV? Well, yes, Washington State in the United States, the State Board of Health there is going to discuss the Washington CMV project petition that will mandate newborn screening for congenital CMV. Canada, Ontario has already commenced a universal newborn screening program. And other countries are also considering universal newborn screening for congenital CMV. So it certainly is a hot topic. There are many congenital CMV advocacy efforts in the United States looking at universal and targeted newborn screening for congenital CMV. The National CMV Foundation website shows the state and the status of congenital CMV legislation in the United States. And then if you go on social media, Facebook, Twitter, Insta, etc., there are a wide variety of advocacy efforts by groups and also by individuals supporting and promoting education about congenital CMV. And so I'd like to end with a bit of inspiration. I would like to motivate you to accept the congenital CMV challenge and to take some next steps forward. And there's a quote that I like. It's, if we stumble, it will not be because we lack for technology, vision, or motivation. We all have that. We have the technology to detect CMV. Many of us have that vision, and families and doctors who care for these babies have the motivation. But if we stumble, it will be because we cannot set a direction and march collectively into the future together towards this common goal. Thank you for listening, and this is Gail Dimler-Harrison signing off.
Thank you, Dr. Dimler-Harrison. Now let's welcome Dr. Stephen Kleibacher, PhD, Chief Scientific Officer for Eurofins U.S. Clinical Diagnostics. He is responsible for the scientific direction and oversight of the company's research and development programs. Dr. Kleibacher is board certified as a high complexity laboratory director, a technical supervisor, and clinical consultant by the American Board of Bioanalysis. Dr. Kleibacher has served as both principal investigator and co-investigator on numerous government-funded research grants of the NIH and USDA. Dr. Kleibacher received his PhD and DMV from the University of Missouri.
Thanks for the introduction. Today I want to talk to you about quantitative PCR for the diagnosis of congenital CMV, and I'll go through a few of the assay details at Viracor Eurofins. So first, a little bit about assays that detect and diagnose CMV. A newborn baby's saliva, urine, or blood can all be tested for CMV. Of these specimen types, however, only saliva is simple and non-invasive and actually quite easy to collect. qPCR as a method of detection has a number of advantages over other methods such as culture in terms of speed, sensitivity, and turnaround time. A few important details for the most accurate diagnosis of congenital CMV are, first, that the specimens must be collected within the first 21 days of birth to confirm a diagnosis of congenital CMV. And when using saliva samples, the swabbing must be done at least 90 minutes or ideally 120 minutes after breastfeeding, as CMV can be present in breast milk. Targeted congenital CMV screening is mandatory in some states, such as Utah and Connecticut, and this is for neonates that have failed the newborn hearing test. And finally, why do we want to diagnose congenital CMV? Well, the most important reason, at least in my opinion, is that early treatment within the first month of life with drugs such as ganciclovir or valganciclovir can provide the most benefit and reduce the incidence or severity of permanent hearing loss. There have been a number of studies comparing two of the most common specimen types for congenital diagnosis of congenital CMV. This is a study that looked at urine and saliva and compared the results for the two. So you can see in this one table, the first table, saliva PCR was positive in all 80 of the samples and picked up an additional sample compared to urine CMV. So when we looked at PCR results for CMV from saliva, we had 80 out of 80 detected versus urine, which was still pretty good, but 79 out of 80. Other studies have also confirmed that urine is not as good a sample as saliva. And so given the ease of collection, we believe that saliva is one of the optimal samples for diagnosis of congenital CMV. This study looked at viral load. So the viral load is an important part of the assessment. In this study, the median viral load in saliva at screening and enrollment of newborn babies with congenital CMV was quite high, 2.0 times 10 to the 6 to 1.1 times 10 to the 7 IU per mil respectively. And that was a little bit higher than urine, significantly higher in this case by about 10-fold. However, there was no significant difference in the viral load of saliva and urine from infants with and without symptomatic disease or in infants with or without congenital hearing loss. So the key point is if you look at this graph, again, about 1,000 copies per mil, which I'll come back to that in a minute, 1,000 genome equivalents per mil in this study. That caught nearly all of the patients that had congenital CMV for the saliva. Viracor has been running a CMV qPCR assay for a number of years. We went through some initial analytical validation to ensure that this assay was also accurate for saliva on swabs. When we had looked at the matrix effect for CMV spiked onto swabs, you could see that there was overall no difference between the observed and the expected value, with a slope nearly 1 and a very high R squared. We also realized that stability is important, as these samples are often shipped overnight to us at either ambient or room temperature, or pardon me, ambient or refrigerated temperature. And you can see based on the orange line that even up to 2 to 4 days for swabs in either this universal transport media or dry swabs, there's very little, practically no decline in viral load on the swabs, indicating that both of these specimen types, either dry swabs or swabs collected from the infant and placed in UTM, can be shipped with no loss in stability. We also looked at a validation series with patients that were confirmed to have congenital CMV and then some that were also not, and compared this to the cell culture result. So the cell culture result is in the third and fourth column, and then the qPCR result is in the fifth and sixth column, and then the days post birth are shown in the second column. So some of these do exceed that 12 days, or pardon me, 21 days that I mentioned earlier. But for all of the infants with a positive cell culture result, we also had a very strongly positive qPCR result indicating good concordance. There was one infant 8 days post-birth that had a negative cell culture result, but a positive qPCR result, indicating that, again, qPCR is probably more sensitive, although this was a pretty small series. Now, this next infant, C116, 3 days post-birth, negative by cell culture, and we had a faint positive by qPCR, but we report this as not detected, again, because we use a cutoff, a threshold of 1,000 IUs per mil. Just a few of the guidelines to summarize. Again, it's important that the sample should be taken within 21 days of birth, avoid collecting near breastfeeding. And then finally, this last point, 1,000 IUs per mil, is the cutoff that we've established for the Eurofins Viracor method as detected. So it's based on a review of the literature, that one graph I showed you in the second literature slide, as well as in-house data. Why do we use this copy of 1,000? Most importantly, it provides optimal sensitivity, so we detect the true positives, the congenital CMV cases, but we minimize the risk of false positives. As you know, CMV is a fairly common virus. Any contamination along the way could lead to essentially a false positive due to analytical contamination, and so that is something that we need to avoid in the diagnosis of congenital CMV.
Thank you, Dr. Kleibacher. Finally, I'd like to introduce Amanda Devereaux. Mrs. Devereaux graduated with her bachelor's degree in nursing in 2007. She has worked in public health for 13 years, most recently focusing on maternal child health. Currently, she works as the program director for the National CMV Foundation. Amanda became passionate about eliminating congenital CMV when her daughter was born in 2015 and affected by the virus. Amanda serves on the Congenital and Inherited Disorders Advisory Committee for the state of Iowa, the Nurse Family Partnership Community Advisory Board, and is co-president of Iowa Hands and Voices. By practicing evidence public health interventions, we can improve the lives of infants and families.
Hello, and thank you for the introduction. I'm very excited to be here today and talk to you a little bit about the National CMV Foundation advocacy efforts. As was mentioned, my name is Amanda Devereaux, and I'm the program director with National CMV. And our mission is to prevent pregnancy loss, childhood death, and disability due to congenital CMV. And I'm not sure if it's been mentioned yet, but we did update our mission within the last year or so to include that pregnancy loss piece, because it is there is research out there that CMV is actually a pretty big contributor to miscarriage and stillbirth. So we do have an updated mission statement. And how do we work to complete the mission? We support science-based interventions, including CMV vaccine development, hygienic precautions for people who are pregnant or thinking about having a pregnancy, investigational treatments during pregnancy, newborn CMV screening, and treatment, early intervention, tracking and monitoring of children who are born with the virus. And so just to refresh our memories here, I'm sure that this has been mentioned before, but what we're really trying to work on is awareness. And so if we look at the orange dots here on the chart, about 6,000 children each year are going to have a disability due to congenital CMV. It's about the same number as Down syndrome every year. But if we look at the blue bar, we see that most people have heard of Down syndrome. And so that's kind of what we want. We want things with a higher incidence to also be very commonly, for people to be commonly aware of those things. And if we look at the blue bar for CMV, we see that only 9% of women in this study had heard of CMV. So we call that the awareness gap, and that's something that we're working on changing. So our advocacy efforts are really geared towards prevention, awareness, and newborn screening. And these are just a couple. The left is a handout that we have for people who are pregnant, and the right is a graphic that we used last year for our Screen for CMV campaign. It's really the position of our foundation that all babies should be screened for CMV. So what are some of our key programs? How are we working on our advocacy? We have a program called our CMV Community Alliance, or our CCA program. We're in the 4th year of that program, and I'm going to talk a little bit more about that in detail on the next slide. But this is really an ambassador program. It's made up of mostly parents. I think we have one grandparent this year to a child with CMV, and they're trying to make a difference in their communities. So they have goals related to increasing awareness, fundraising, and currently we have 20 chairs in 16 states. We also work a lot on education and outreach. We provide educational materials on our website, and we're also focused on educating families, women of childbearing age, healthcare providers, childcare providers, to let them know that they can reduce their risk of contracting CMV during pregnancy. We also fund research, so we have funded over $100,000 in research since 2018, and in 2022 alone, we are planning to fund $100,000 in research. So for our CCA program, we currently have 20 chairs, like I said, in 16 states, and this map just shows you where they are. If you know a family in an area where we don't have somebody, we'd love to have them. We're always looking for new chairs. And like I said, these ambassadors are really focused on spreading awareness in their area. Some of them are working on legislation. They're hosting fundraisers. They're talking to doctors in their area. They're trying to get partners involved, like their state public health agencies or their state early hearing programs. And so these are really our boots on the ground trying to spread the word about CMV. There's also been a lot of work in the past several years related to CMV legislation. I think a lot of parents, when this happens to them, they want things to change, and they want things to change quickly. And so they want to make a change happen in their state. And one way that that's happening is through legislation. So just some updates on more recent legislation. Minnesota is going to be the first state to screen every baby, and they are going to start doing that hopefully at the very beginning of next year. They're already in the planning phases for that. Nebraska signed an education law this past year in 2022. Kentucky passed an education and hearing targeted screening law, and that law also is going to screen for some other risk factors, but those have not been written into the statute yet. Florida signed a hearing targeted bill this year, and Maine passed a hearing targeted and other risk factors screening law this year, and their goal is to expand to universal screening. Massachusetts has a bill pending for universal CMV newborn screening and an education component. Pennsylvania also has a bill pending for hearing targeted testing and education. And then we have had bills submitted in the past for Indiana and Michigan, but nobody has, I don't think any of those have been resubmitted for this year. So this work is continuous. If you know people in these states that haven't passed anything yet that want to work on something, we're always happy to meet with the advocates in the individual states and really help let them know how it's been done in the past and how they might get it started where they live. And another thing I think it's important to talk about is that some states don't actually require legislation to start screening babies for CMV. Some states have a process through the health department. And so that's really important for people to know that legislation is one avenue to start screening babies, but there's also sometimes the opportunity to implement some screening without going the legislative route. And so we're always happy to consult with people about that on an individual basis as well. These are just some resources that are available on our website. We've been trying to update some of our educational materials and resources for families especially, but we've added a brochure just about the National CMV Foundation. We always have our general CMV awareness, which talks about the CMV prevention measures. We have a new brochure about the relationship between CMV and newborn hearing screening, since a lot of times CMV newborn screening is tied to the hearing screening. We have a roadmap for congenital CMV, so it's really important, and I know that the doctors have probably said this in their presentations, or they will, that infants who are born with CMV need a really thorough workup to determine the severity of disease. And so this is really a guide for parents and providers as to how that should be accomplished and approached. And then we also have a next steps after a CMV diagnosis, and this is really geared towards families. Just what resources are available once your baby has this diagnosis? What are some different people or disciplines or specialists that you might want to have involved if your child has this diagnosis? And this is by no means all the resources on our website. There are plenty there, but please feel free to visit our website and have a look. So CMV Awareness Month is coming up, and these are all of our events that are happening during the month. I know that this webinar is happening after some of these events. So things that are coming up, we have our Rigoni concert. So one of our board members is, he does a Facebook Live concert every year, and he takes requests, and it's really fun. So it's just a fun way for us to do a fundraiser and have some music streaming over Facebook Live. So please look for that, and definitely stay tuned to all of our social channels for Awareness Month, because we're always adding more events. And then just in general, all month, next month in June for CMV Awareness Month, and just really all year, stay tuned to our social media, because we're always adding new things, and spreading the word is very, very important when it comes to CMV. And that's really all I have. We would love to hear from people who want to get involved with CMV advocacy, and you can connect with us via our website. We also have just the info@nationalcmv.org email address that we answer. So if people are looking to get involved, please let us know, or you can connect with us on any of our social media channels. Thank you.
Thank you, Amanda. I'd like to express my appreciation for our presenters and also for your viewers' time today. This concludes the presentation portion of today's webinar. We will now open for a Q&A based on the questions submitted during the presentation. And if any others come up, feel free to add them in the chat. Okay, we have a few questions. So presenters, if you could go ahead and come off of mute so we can answer the questions that have come in. I will get started with Dr. Demler Harrison. Can you share a little bit about how and when your center tests for CMV? Are you able to share your testing protocol, and how does targeted screening at your center work?
Those are really good questions. And so at Texas Children's Hospital at the Pavilion for Women in our normal newborn birthing center, babies who fail or refer on their newborn hearing screen are tested for CMV. And we do 2 screens and then 1 mini ABR. And if all those are failed or referred, then the baby through our process will be screened for CMV. And we leave it a little bit open to the provider and the individual circumstances of the family as well. And so we'll accept a CMV culture or a CMV PCR and we will accept either urine or saliva.
Okay. Another one actually has come in about the RESP application for CMV. Is there any update?
I might want to refer to Amanda in the National CMV for any updates, because though I'm part of that committee, she probably has her finger on the pulse of exactly where we stand. We've been waiting for a couple years for something positive. But Amanda, do you have anything to help us with a right now update?
Yeah, sure. I can do that. So we actually submitted a few years ago, and then we resubmitted last October. And so the committee has our nomination. We have gone through a completeness review, and right now we're following up with the committee for some follow-up questions. And we're hoping that we'll get word on whether we're going to have a full review or not, hopefully by the end of the summer. That's kind of our goal, is to maybe have a news either way by the end of the summer.
Good news.
Great. Okay. I have another question coming in along. Are you all considering screening for all latent infections that can cause birth defects, such as HSV? Can you share how CMV compares to neonatal herpes?
I'll take that one, because I do care for babies who also are affected by herpes simplex virus infection, and that's an absolutely devastating herpes family virus infection as well. And babies can be congenitally infected with HSV. That's the minority of them, but they can be left devastated from that infection or die in utero, so it's an important cause of stillbirth. Or they can have neonatal infections of just their skin, eye, and mouth, or their brain, or can have disseminated disease that has a very high mortality rate. So the focus of this right now is for cytomegalovirus, a cousin of herpes simplex virus. But I, as a pediatric infectious disease specialist and a specialist of congenital and neonatal infections, and sort of a super specialist in the herpes family virus infections, I absolutely endorse more awareness about herpes simplex virus infections of the fetus and the newborn. Maybe we can talk offline about some advocacy efforts for that. I'd love to help.
Great. Okay. Dr. Kleibacher, how quickly are results received by physicians if they send CMV saliva testing to Eurofins ViroCor? What is the turnaround time?
Yeah, we typically perform the testing the same day we receive the sample. So it may take a day or so for the results to actually reach the physician, depending on whether they're communicated electronically or through something traditional like a fax, but it should be 24 hours approximately for most cases.
Yes, and I use that, the test clinically when I want to do saliva PCR, and I'd endorse that we do get the results back in a pretty timely manner for for clinical use.
Good to hear.
Great. Dr. Purcell, at what point does a patient and their family get referred out to otolaryngology, and what can they expect if they are referred out to you?
That's a great question. To follow up on Dr. Demler-Harrison's note about the hearing screening, so typically a child would go through a hearing screening process that differs a little bit depending on the institution. But most importantly, if they refer on that hearing screen, then they need to have a diagnostic study to confirm the presence of hearing loss. And once that's done, typically that would be done in coordination with an otolaryngology appointment, especially if the child is found to have hearing loss. And so the majority of my practice in regarding children with congenital CMV is related to children who have hearing loss. And importantly, congenital CMV is the most common non-genetic cause of sensorineural or permanent hearing loss in children. And so it's very important to monitor their hearing over time. The Joint Committee on Infant Hearing has included congenital CMV as a risk factor for hearing loss. And so children need to have regular testing if they have congenital CMV up until at least the age of 5, if not longer, to monitor their hearing.
Great.
I'd like to echo what Dr. Purcell said, that the follow-up of the newborn screening results is really key. And so I follow them up at our institution, and we have a whole team of otolaryngologists, audiologists, and and if needed, speech language therapists to follow these babies as well as the pediatrician. So that's a key component in the algorithm as well. So
that's great. Thank you. Okay, this one, I'm not sure who will field it, so if you know the answer, please feel free to speak up. Are there any reimbursement issues between implementing universal screening within a center for cCMV versus targeted screening for cCMV?
I'll take it here. That was discussed, and so with targeted screening for CMV, it was felt by our committees, and it seems to be true that it's an indicated medical procedure because the baby has something wrong, and it's a diagnostic test to try and determine what might be the cause. So we haven't had any issues that way. Now, universal newborn screening might be a whole different kettle of fish and very worthy of discussion.
Great, thank you, Dr. Demler-Harrison. Okay, Amanda, a couple questions for you. First off, how did the Strides for CMV go earlier this month? And are there any advocacy efforts you are personally looking forward to the rest of the month?
Yeah, sure. So the Strides for CMV worldwide happened on June 4th, and that was a huge success. We had, we're very grateful to one of our sponsors, Moderna, and then we had great participation. We met our fundraising goal of $20,000. So that was a huge success. We had participants from all over. It was great. And I think I think it's the end of the month, we have a concert on Facebook Live. One of our board members does a concert. His name's Zach Argonian, and that'll be on the 24th in the evening. And so people can hop on Facebook Live and request music. It's always fun to try and trip Zach up and request something kind of interesting and fun. So I think that's the one I'm looking forward to the most.
That's great. It sounds like a lot of fun, so I could absolutely see that. Okay, we have another question. How can citizens help move these universal testing initiatives forward in their states? What's the best way they can get involved?
I might take that, I guess. Well, I would say reach out to us because we'd love to make sure that you're looped in with people who might already be working on something in the state. We want to make sure people aren't duplicating efforts separately, and so we can kind of loop people in together. So I think it's really about connecting with us, gathering your troops, if you will, the people, the stakeholders who would have an interest in this, and then formulating a plan. But we're happy to assist with those things, and looping in the docs in the state is just absolutely so important because their opinion holds a lot of value in the state. And then of course you've got to have parents and other stakeholders at the table too. So that would be my advice, is connect with us. We'd love to make sure that you're connected with the right people in the state.
Absolutely, thank you, Amanda. Okay, I have a question that I can answer. Is this being recorded? And if so, will we be sent the link to share? Yes, it is being recorded, and yes, we will be sharing the link after the presentation is concluded. So you will be able to share that with whomever you think would love to see it. We would love to have you share it. Another question for our physicians here. Are you currently testing newborn blood spots retrospectively due to the 21-day newborn window requirement?
I can take that one. I'm sure everybody can, but yes, it is a very valuable way to go back in time because many babies will present after that critical diagnostic window of opportunity of 21 to 28 days. And so I have used that successfully. It is, however, difficult to find labs, either research labs, government labs, or commercial labs that will accept newborn screening through newborn dried blood spot. And there is a process, so it's not as simple as ordering, say, a saliva CMV PCR. You have to get parental permission, and then you have to, acquire it and then send it to the lab. So I do use it. It is a process, however, but it is quite a useful way. I think upfront would be better, like Minnesota is doing, and screen newborns for congenital CMV at the state newborn screening lab at the time other newborn screens on the dried blood spot are done.
Yeah, and that really gets in. the crux of targeted versus universal versus not doing testing until they start displaying symptoms, right? And why it's so critical to catch them in that 28-day window. So if you've got targeted screening or universal screening already set up, you have that sample already collected. You don't have to go back to that dry spot that was collected at birth, right?
Exactly, yes. Doing it up front during that critical window of opportunity is the best approach. But reality is most babies still are not tested or screened for congenital CMV.
As an
Absolutely.
otolaryngologist, I tend to see a lot of children with delayed diagnoses because the first sign is the early progressive hearing loss, because they otherwise were essentially asymptomatic at birth. And, you know, fortunately in Michigan, they do store the dried blood spot until 18 years of age. And so I use it quite regularly to diagnose children, but not all states store the dried blood spot in that fashion, and some destroy it within 6 to 12 months of birth, and then it's not even an option. And so you're really left with a diagnostic dilemma in some cases where we're not able to truly confirm a diagnosis. And so that's where early screening can help provide these families with answers, where, you know, I do have a number who are you know, the families may never really be able to say for certain. We're highly suspicious, we can't say for certain. And so that's a benefit of early screening.
Absolutely. Thank you for sharing, both of you. All right, and it looks like for now, the final question here, if anybody else has questions, please keep them coming. This has been a great discussion. But the final question I have up on the screen right now for Dr. Demler-Harrison, what is the best screening test?
Oh, that's a really good question. I don't know what's the best one. Each one has pluses and minuses. So if we first take saliva, that sample is very easily available, and we do have methods to test. And I think saliva newborn screening for congenital CMV, actually, if we could even develop it further to be a point of care bedside test so that every baby before they leave their birthing center gets tested for CMV. We could, you know, have sort of a platform with a small footprint that could be in every newborn nursery. I think that would be awesome. But it is, you know, probably the most convenient sample. Urine is also sort of the traditional reference standard, and it's a good test as well. But both of those, you know, require that the doctor either order it or it has to be done clinically. If you use newborn dried blood spot, that platform is already in place through newborn screening for other congenital and inheritable diseases and metabolic diseases. So that has a distinct advantage that way, in that the platform's already there. You don't have to have a new platform or a new test. So in that regard, it has advantages. I honestly think we could talk forever about what's the best one, and we need to wait until we decide what's the best one. I'm more action oriented. I say choose one, choose them all. They all have their own pluses and minuses. We just need to move forward collectively towards doing something. Give one of them a try and see how it goes. I don't know if anybody else has any kind of ideas about what's the best. I think they're all good. Let's just start.
Yeah, I totally agree. I think it's more challenging to get a urine sample than a saliva sample. I think that is a really kind of a basic when you're trying to decide between the two. So it could be one potential benefit for saliva, with understanding that saliva does have a higher false positive rate due to the breast milk exposure. So, you know, just making sure that the timing of the sample collection is appropriate.
Absolutely. And it's recommended to wait, is it 90 minutes after breastfeeding to collect the sample, typically, if I remember correctly?
Yeah, we'll often wait a couple hours, if possible. It's hard in the newborn. But as a pediatrician who does, you know, urine samples pretty routinely, it's reasonably easy if we have a saliva that's positive, they confirm it with the urine, either, you know, in the pediatrician's office or the peds ID office. So, you know, start with the saliva and then do confirmatory if you have any kind of issue with the urine. Is certainly a great way to proceed. Yeah.
Absolutely. Great. Okay, I think let me double check and make sure we don't have any other questions. But again, I would like to thank everybody for their time today and for joining us for this great webinar about the importance of early screening and universal screening for congenital cytomegalovirus. That concludes today's presentation. We will be sharing a link so you can watch the presentation again on demand or share it with your friends. Thank you so much. Have a great rest of your day.
Thank you.
Thank you.
Hey.